trying that. So it will have a single gateway option in which anybody from the provider side can raise the claim to anybody on the payer side. No need to open multiple portals, because it also causes a lot of time wasting and everything at a TPA desk. So we have set up a standard protocol in terms of FHIR, and then we have set up this gate. So this sender and receiver code NHCX validates in this and then sends it to the relevant payer, who will do the adjudication on this behalf. So they will do all the claim processing and send the response back to NHCX and route again to the provider side. And one more important thing is that what are the various gateways that we are using? What are the various building blocks that we are using in terms of the ABDM? So, like Himanshu said, ABHA is one of the key identifiers. ABHA is the way in which we are going to identify the individual beneficiary. So, what is the first step when we have to start with NH6 integration? We have to link our policy with ABHA. So that functionality has been implemented by almost all the payers, and which maybe you can also try and ask your companies, or maybe visit, if anybody has taken any private insurance, they can visit their website, and there you will find option to link your ABHA with the policy. So maybe those who are present here can do this exercise and visit their website of your respective insurance companies and link your ABHA with their policies. One of the major identifiers in which we are creating a participant, which is a unique participant on NHCX, is through the HFR. So adding the HFR details in our system, and then we create a unique participant ID for a particular hospital. That is also a repository that we're using. We are maintaining a payer registry as well in association with IRDA. So that is a way to go, and we also have digital contracts. So below you can see that we are trying to develop a PHR application functionality for NHCX as well. So currently what happens is that only the insurance companies and the providers are aware about what is going on in NHCX. But we want to give this functionality to the beneficiary as well, in which they will have an ownership. So for example, if you have encountered any admissions in the hospital, you are not aware that why this discharge is taking so long when you are doing this. Why is this pre-authorization taking so long? Are we missing any documents or not? So then people you up and ask the information. So by enabling this functionality in the PHR app, we will use ABHA as a single identifier, and in which we will be able to track the status of claims. We will be able to search our policies. We will be able to search at what stage the information, or at what stage the claim is pending right now. Yeah. Yeah, so the digital contracts have a provider and the payer. So a unique participant ID is created, in which you will know that this participant is a valid participant and they are allowed to process their claims. So this is a kind of a digital contract that happens between a provider and a payer. So one of the things that we have, in order to submit a claim to a particular insurance, we have a concept of public key and private key. So unless and until you fetch that key from the payer side, you will not be able to submit it to them. Some sort of digital handshaking is happening via the NHCX. No, this happens all in every scenario. This is the basic scenario. So before processing it, so you have to you understand the concept of the public key and the private key. If you are able to get the private key, then only you will be able to decrypt that bundle from a particular company. So that is a more technical thing, that how we encrypt those bundles and how we decrypt those bundles. We can do that using the private key of the payer. So that is part of the digital contract. So if we are not having that key, then anybody cannot decrypt that bundle. So you have sent it to I have an HDFC policy, and by mistake a provider sends it to MediAssist to somebody. If I do not have the public key of that particular provider, I will not be able to decrypt that. So that is kind of a digital contract that happens.
So, is there any standard encryption methodology that has been used across the paying system?
Yes, so we have used RFC 766 or something
So
like
is
that.
that common across the whole insurance sector, or is it
Yes,
some
we have
different?
mandated it to use in terms of NHCX. That is part of the protocol.
So it means that any insurance partner, be it HDFC or anyone, it would be having that only that kind of encryption to.
Right, right, right.
That's the only thing is to get the retrieve that public and the private key.
Correct, correct. So let us highlight a few of the capabilities what NHCX delivers. These are some of the functionalities that are required in terms of and the benefit or the added advantage that we gives to the provider and the payers. So one is the coverage eligibility. So for example, if you are going to a hospital and the hospital does not know that your coverage is in force or not, maybe it starts from 6 months of you taking the policy. So coverage eligibility is a feature in which the provider will send a request to the payer and they will get an information if your policy is in force or not. So this is something that has been enabled by NHCX. Another thing is status check. So at every instance, we can check the status where our request has been. So is it pending at a pre-authorization level? It is it there at the claims level? Are they doing something with it? Like if they are adjudication or they are processing that request, then also this information we can get from NHCX. We have integration with multiple registries, like I highlighted before. We have HFR registry, we have ABHA, we have AI registry, in which we use that information to validate the participants. So the payer side ecosystem is quite limited. It is the provider side that we do not know about. So payer, we have only 49 insurance companies and TPAs in place. So the payer registry is being maintained by IRD, and we only have to integrate with all of these private insurance companies. Another thing that is an standardized machine readable insurance plan. So insurance, what insurance plan is, you have your policy, right? It is in a PDF format in which you get the information about what are your inclusions, what is covered in a policy and what is not covered in a policy. That information is there in a standard FHIR format in which a hospital will get to know about that information, that this service is available and this policy can be claimed for a particular patient. So for example, some of them might not have a dental cover in their policy, but the hospital will not know if the dental cover is there in the policy or not. So using the fetch insurance plan, they can get the information that this is covered or not and what are the limits attached to it. We do NHCX participant verification, that only verified participants using their HFR and the insurance ID that we have are able to register on NHCX. We provide the real-time participant information to everyone, so they can get a list of participants who are already live on NHCX using an API, and they can process their claims. So few of the functionalities that are there. So we have these are the APIs also. So these functionalities are related to the APIs that we have, and these are all functionalities any particular provider or payer have to implement in their system. So it starts with coverage eligibility check, pre-authorization. So pre-authorization is basically an approval that we take before a patient is admitted to a hospital, right? You have to take a request from the your particular insurance company that we are getting admitted to this, and you will cover the cost of our admission. And basically, it is an intimation to the insurance company that this patient is getting admitted to this hospital. Then we have claim submission, which is self-explanatory. Communication request response. These are the set of APIs in which, for example, if an insurance company raises a query, so this query travels through the communication requests, in which we can ask for more information on a particular missing document, or we can request some other additional information in terms of the patient or something like that. Then we have payment notice. One of the major pain points that the hospital have currently is that they raise a claim to an insurance company, but the payment that happens usually happens in a bulk format. Like after 3 months, an insurance company will pay for the claims that are there, but the hospital have no way of identifying how much amount they have received for a particular patient. So, for example, there are three people, and the total claim amount comes to be 10 lakh. they pay the 10 lakh, but they do not know what is the individual breakdown of that 10 lakh. Maybe they have paid for 8 lakhs for a particular person and rest they have not paid for anything. So this payment notice is one of the highlights of NHCX, and which the payers have uh, shown their interest in getting to know about this and integrating in their system. We have a reprocess request. So, for example, if a provider is not happy with the amount that has been settled, so I have raised a claim for 1 lakh rupees, and an insurance company pays me only 50 without any explanation. They can use this reprocess request and can ask for an explanation that why have you done it? Please consider it again, and you can reopen that case. So, insurance plan details I have highlighted above. Right. Yeah. Sure. Right. So IRDAI is Insurance Regulatory Authority of India. So these are basically the regulators for insurance companies in India. So insurance is a regulated organization, regulated market, and IRDA are leading, are basically on top of it. So they maintain the registry for all the insurance companies. They maintain all the claims that have been settled through them. You can raise a grievance request to them if your claim is not getting settled. So IRDA is basically the head or the regulatory body for all the insurance companies in India. So taking the question of Sanchit, so tracking the status, we have a set of APIs in which at what stage an insurance claim is at a payer side, we can get that information. So for example, if I have raised a pre-authorization request and I'm not getting an information, I can hit the status API and get to know that whether the payer are processing it, whether it has received, the request has reached the payer or not. First is that step where they know that the information has been dispatched and it has successfully reached it. And if there it has reached, then are they processing it right now, or have they sent the approval or not? So at all stages, like the request has been reached, they are processing the claim right now, how much time they are taking, if they have completed that processing and sent a response back or not. So this all can be tracked through a status check API. Another thing that hmm. Right. So some of the insurance companies are at an advanced stage in which they are doing it. Not everybody is, yeah. So like I explained it in the last slide, our application is in works. So in which you will get an information if so you get an information that it is at a payer side or not, if the claim is in process. You can track it through the PHR application as well. This is a feature that we are also enabling it right now, and not in the PHR app as well. So you can submit your reimbursement claims on PHR app as well. So reimbursement, and usually you take out all the printout copies and send it to the insurance companies. In the next feature, in the for the reimbursement claim through the PHR app, you can scan all these documents and send it to the insurance companies. Every insurance company have some of the advanced one have their own PHR application, but you cannot send from an HDFC Ergo PHR app to any other insurance company. So a PHR app enabled by NHCX, you will be able to do that in future. It is in works. We are currently working on it.
Two questions here. First, what is the kind of data set that you have in this IRDI data registry that you are talking about? Second is that what is exactly the data that NXCS is having in the own ecosystem?
Right. So in the IRDA registry, we have the information of all the insurance companies. For example, the name of the insurance companies, what is their registration ID that they have given. So IRDA provides a unique ID to all the insurance companies. So that is maintained in a IRDA registry. So that information is validated so that any insurance companies that are in market which are not regulated, there can be some entities like a broker or somebody doing a micro insurance on your behalf, but they are not regulated by an insurance company. That information will, so we will get a flag that this is not part of the IRDA registry. So they maintain unique ID like we do for an HFR, that we have a verified information of all the health facilities. Similarly, IRDA maintains a registry for all the health insurance players in them. Sorry, what was the second question?
What is the kind of data set that we have in NHCX?
Right. We have a set of, like I mentioned, that we have a protocol header and a payload. So the information about a particular claim we cannot read. That is an encrypted format. In the data header, we have information like who are the participants, what is the details about all the participants that are on, what are the bridge URL that they are using, what is the, so we have a concept of workflow IDs in which we get an information that if they are raising a particular request, what is the scenario for it? Like if they are using a discharge request, if they are doing a discharge request, a patient discharge, or they are submitting cashless claim, or that kind of information is stored in NHCX. We have mostly the participant information, the headers, the ABHA is stored, the ABHA and the policy link to that is stored in NHCX. Then we have this information about the workflow IDs that are there. And these high level informations are there. You can refer, we'll share the website link with you. There is an information on what are the headers and what NHCX stores. You can go through it later.
Uh, yeah, just to add to that, NHCX can't read any of the other specific claims processing data.
Same as a federated architecture.
Yeah, because a lot of the times one of the challenges is the transparency issue, right? Like with adoption, is the changes like surveillance or something. But because NHCX can't read it, it's we don't have a lot of that data. We only have whatever I've mentioned.
Yeah. I will cover your points and it's later. Yeah. So, one of the other things that I want to highlight that some of you might not be aware about, and I've been asked this question multiple times with different people, if is NHCX live or not. NHCX is very much live. We are processing information, we are processing claims through NHCX. Currently, we have 46 integrators on production. Out of 31 insurance company, 28 are already live. 3 are in under development. They are probably at an M1 stage. We have 11 third-party administrators and 7 DSCs onboarded currently. We have a set of 537 private hospitals also on NHCX, which are processing their claims via NHCX. 90,000 insurance policies have been linked to unique ABHAs, and 228 insurance products are onboarded. One of the other things that I want to highlight, we have another scheme running, that is the PMJ, Pradhan Mantri Jan Arogya Yojana. So they also have a claims management system on the payer side that is also completely running on NHCX. NHCX is the gateway in which they are using to transfer their information. So it is live in 34 states in India already, like, and it is processing more than 1 lakh claims daily for PMJ ecosystem. नहीं, मैंने पीएम इसमें पीएमजे का मैंने कवर नहीं करा, ये प्राइवेट फैसिलिटी का इंफॉर्मेशन है. पीएमजे का तो अराउंड 10 लाख हो चुका है, उससे ज्यादा ही है. 34,000 हॉस्पिटल्स भी वहां पे ऑनबोर्डेड. राइट. यस. हाँ. ओके. 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 राइट. राइट सर. हाँ. राइट राइट राइट. ओके. Right. 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 Okay. Correct, correct. Yeah. Right. Right. We get your point. We'll work on it. Ki what is the consumer side of it? We'll prepare some document in this. But in general, an insurance, in this case, if you're linking a policy, so for example, if my policy expires in some time, and if I take a new policy, we have given that right to the insurance company in which they can delink that also. So it is an onus on them to maintain that registry running, that they are linking and delinking it simultaneously. So this number of policy linking usually fluctuates. So sometimes it is high and sometimes people start delinking the process, and in a scheduler format it can reduce as well. नहीं
So
सिर्फ
that was. Is
हाँ,
there any role of
no.
ABBA address here? Is that the case?
So right. Mike.
Yeah, I know. I think I'm aware of this issue. I think it gets mapped to the Yes, sir. It maps to the default address, the preferred one. So we are speaking to the technical team to understand how, because we are more of the functional side of things. We've escalated it and we've told them. So yeah.
अभी
ABBA number.
अभी आबा एड्रेस का कोई यूज नहीं हो सकता, मतलब हाँ, मतलब वी जस्ट यूज एन आबा नंबर, उससे हम अपनी पॉलिसी लिंक करते हैं, एंड दैट इज द ट्रांजैक्शन आईडी आल्सो फॉर, सो उसी आभा, जब वो प्रोटोकॉल हेडर में मैंडेटरी है तभी आप प्रोसेस कर सकते हो और उसी के अकॉर्डिंगली वो चलता है, तो वी आर जस्ट कीपिंग आभा एज अ रूल. नहीं, वो कह रहे ना वो डिफॉल्ट लिंक होता है. हाँ,
So that is not a problem. कि, हाँ. Okay, if it is only ABBA, right, and you pick up some different ABBA addresses, otherwise I was thinking something else. If ABBA address is there, then in that case, how you ensure
no,
the KYC of that?
so we are
So
using
I got
Java.
your.
So I'll quickly hand it over to Meghna now. Thank you.
Thank you, Raghav. So before we move forward, what is the full form of NX? Great, people are listening. So yes, moving forward. I'm glad. Okay, so giving you a quick walkthrough of whatever we discussed, NHCX is a data exchange platform. It is a gateway that aims to bring all the ecosystem players on a single platform. So the objective here is to claim processing and bring interoperability. And with this, we have multiple set of partners who we are actively engaging with, and the progress slide that you saw is because of these partners mostly. And we have the regulatory authority and development authority of India, IRDAI, with whose confluence NHCX was formed. We also have GIC, General Insurance Council. This body acts as an insurer for all the insurance companies itself. So we have an insurance company who cover our claims. Similarly, GIC is the insurance company for all the insurance companies present in India. And as a part of catering to adoption challenges, we also started a track called Champions of NHCX, wherein we are selecting some key players from the ecosystem itself to, face these challenges and curb this at its very point and move forward with the adoption. Some of the champions we have with us as of today is Swasth Alliance, Nat Health, AHPI, and India InsurTech. Alongside, we have some of the digital solution companies who work on behalf of providers, that is hospitals. They are IHX, Claimbook, Vidal Health. So these are the largest contributors for NHCX growth so far. And on the payer side, we have both TPs and insurance companies. So MediAssist and Paramount have been one of the top performers with NHCX, who are processing claims for the past 1 year on behalf of insurance companies. So moving ahead, of course, we spoke about the ecosystem challenges, and now we have some challenges in adopting NHCX as well. So the very first challenge would be resistance to change. Hospitals are following a set process for years now, and they are reluctant in bringing on this new system. So that is where we are facing an issue. And also the technical and infrastructure barriers. Most of the hospitals face shortages in technical staff who are well equipped with IT platform. So they are lacking in digital knowledge and they face difficulties integrating with their existing IT system. So also the ecosystem in general has limited awareness of the digital health insurance process. People also have trust issues and there are regulatory and compliance concerns that bring fears of legal repercussions hindrance. हल करने के लिए steps उठाए हैं and these are some of the ongoing activities. So we know that we have cashless claims and also reimbursement claims, two types of claim processing. And cashless तो अभी चल रहा है. Idea is to bring reimbursement functionality onto NHCX, towards which we are working. And once we bring reimbursement functionality onto NHCX, people, beneficiaries, or the policy holders will be able to track claim end to end. We would be giving them a platform through PHR applications wherein they will be able to track their claims end to end. अभी शायद किसी इंश्योरेंस कंपनी से हमें मैसेज आ सकता है शायद your claim has been started, your claim has been generated, but once you have an access to PHR applications, you will be able to end what is the status, when it started, or where it is right now. So that's the idea of bringing reimbursement functionality onto NHCX. Yes. As of now, we haven't integrated any of the PHR apps. The idea is to get Arogya Setu on board. Yes. We are starting with Arogya Setu, sir. Yes. So we also know that 65% of the claims are group insurance. We spoke about retail claims, individual claims, and the other part of claims being the group insurance claims that your employer provides. So we ran a pilot in the month of January just to increase the adoption of NHCX. So in this slide, we did get a lot of engagement with NHCX platform. And we also made ABHA voluntary for this specific set of claims that was processed through NHCX. And moving forward, we also taking steps towards increase ABHA policy linkages. We are in discussion with insurance brokers who act as a layer between the big corporates who provide the group insurance claims today. So we are bringing PHR onto NHCX. So that is another way of increasing ABHA adoption. And then we spoke about Arogya Setu, of course. And the two states that are not onboarded onto NHCX as of now is Karnataka and Rajasthan. We have already started integration with we just started yesterday, and I'm sure Rajasthan will also be onboarded very soon. So So these brownfield states have the infrastructure already, but are not able to leverage or use it.
Infrastructure for what?
Infrastructure for health ecosystem.
Brownfield. These are the only two states.
These are the only two states that are not yet onboarded onto NHCX. But we have started integration with Karnataka, and we will be soon starting it with Rajasthan as well. So this was mostly about NHCX. Anybody has any questions?
So basically, to us that as a citizen, what I need to do, that do I need to do anything, or as a citizen, just that is it.
As a citizen, you must know that there is an UPI like structure coming in the healthcare ecosystem, which will make claim tracking, claim processing much easier than it is today.
Are we doing anything for the IC? Because
For?
IC.
Okay, as for to add to that, as a citizen, you can also ensure your health insurance is linked to your ABA because your insurance company is the entity that can do that.
I agree with that. Sitting in this room, I can ask my insurance company to link my insurance with ABHA. But as a citizen, the person who are roaming in this ground place.
Agreed. IEC is something that we will be taking up, but right now we are working more on ensuring that the tech is there and in place and is robust and is functioning at a level where we can push it out at where we can do IEC with full force. We are working on awareness, which is our champions that she mentioned. We're working with Nat Health, AHPI on the hospital side, where we're using them to speak to the hospitals because we sitting in this room might ideas exactly about how NHCX helps hospitals or how it can be leveraged to solve their pain points. So that's why we have champions from the market itself to do some of these awareness building activities where we're actually leveraging it and positioning it as a solution to pain points instead of just saying NHCX is there. But yeah, to answer and to add to what you're saying, IEC and awareness is definitely something that we should pick up and work on because before I joined NHCX, even I had no idea that it existed. So yeah.
So the other question is that have faced any challenges from the private sector agencies or the insurance agencies that companies that they are not coming on?
Yes, the reluctance to change, the reluctance to adopt new systems.
So that adopting a new system is one thing, but let's say that if we can influence them by stating some kind of benefits out of it.
Yes,
then,
that's the idea.
So let's say that as a common man, if I'm going to meet any insurance company or any distributor, so which kind of a statement should I put forth to him to opt this NHCX?
Yeah, so within private insurance companies, two things here. One is we work with IRDAI, so we have that, and insurance companies are willing to listen to IRDAI, and NHCX has been mandated by them. So that way, that is one thing for insurance sector side adoption. The second thing, to answer why insurance companies will start using NHCX, they see immense potential in ABA and HFR as verified sources of truth because right now they struggle a lot with fraud management and analytics because they're not able to have a verified beneficiary identification system or a verified hospital facility if it's not a network of, especially for reimbursement. So with insurance companies, we've noticed that that's their biggest sort of pain point that we are solving for. That being said, like every insurance company we've spoken to acknowledge these benefits and they're like, oh yeah, once ABA comes, once HFR comes, it'll be great. Yeah.
Last statement is not a question, it's a suggestion. Let's say that if patient dies in the hospital, okay, so in that case, if let's say that health insurance, the owner of that health insurance, if he has some term insurance or the other life insurances, if we cover those life insurances in the future. So I was thinking that line, yeah, long term vision, that if life insurances or term insurances could be linked with the ABA, and let's say the patient dies, sometimes what happens that might have seen several news that 74,000 crore rupees are lying in the bank because nobody is claiming them. So it could be the case that let's say that the owner of the family or the member of the family is having some term insurance or the life insurance. So the trigger should go to those companies that person has died. That is the authentic claim because it is coming from even the companies let's say that if let's say Niva Bupa has been onboarded on NHCX platform. So even we can think of even with the insurance companies which have already onboarded, and we can also along with the insurance company life term insurance.
हम provide करते हैं. There is no new registry. Yeah, but depending on their role, yes, we will assign them the role of a provider or a payer. हाँ. In-house team, yes. And we give them the production access. M2, M3, right? M1 mandatory. Yeah. Thank you, everyone. Thank you for your time.
Yeah, I have a question here. Can I?
Yes, please.
First is regarding the grievance management. Okay, can you, if since we forefront here for the integrators, in the integration team, so we do get a lot of grievances from NHCX, right? We do direct it with them, but we have often received feedback that the grievance is not resolved in time. They also share that the settlement doesn't happen time. It takes time, right? So I think we should work more on the grievance redressal system. It should be a little robust. That is one thing. Another thing, we should also currently we are mandating only M1, right? But I think we should
Yes.
also start mandating M3. The reason being, when you mentioned fraud, right? That is only to check whether that particular facility has been blacklisted. So anyway, they do have the data, but yes, HFR can also help that. But why M3 is important is that it was also at the time of issuing the policy, right? Many times the insurer, the insured, they never share their history, and there is no way that the insurer can find out all the details whether actually in reality the respective policy, the potential policy holder has had any health history, right? So I think if they do M3, that would help them, identify potential such fraud cases also. So I think we should do for M3 also should be mandatory. And last is just, I think what somebody mentioned with regards to IC, right? I think for NHCX, there has not been localized drives. I think if for enablement, we can maybe we can invest in localized drives for adoption. That's all.
Yes, ma'am. This is something to ponder on, and these points are duly noted. Thank you so much for your suggestions. Anything else to add, ma'am?
No, thank you so much. Thank you so much. That was really nice by Raghav. Sincerely appreciated.
Thank you so much, ma'am. Thank you, everyone.